Hello, everyone, and welcome to the American Society of Cytopathology's or ASC Cytopath podcast. Today, we will be discussing a basic liver cytopathology or demystifying liver cytopathology, a comprehensive beginner's guide. I'm the presenter today. My name is Rosemary Westphal. I'm a recent graduate of Thomas Jefferson University Cytopathology program, and I recently obtained my master's as well as my actual ASCP certification. And I will be working at Robert Wood Johnson Barnabas Health Community Medical Center in Toms River, New Jersey.
And hi, I'm Noa McGuire-Berk. I have a master's in diagnostic cytopathology. I have been a cytologist for about 6 years now, and I currently work for Virtua Health System.
Noah was one of my preceptors during one of my clinical rotations, and she's someone that I trust very dearly with cytopathology. And I would say she's definitely one of the most influential people I met and someone that helped me get through my first set of clinicals as well as my last set because I got to do two rotations with Virtua.
It was an honor.
Thank you. So, just to jump into it, we're going to start with liver sampling. There's various ways you can actually get samples from the liver. This includes fine needle aspirations, fine needle core biopsies, endoscopic retrograde cholangiopancreatography, or ERCP, as I will refer to it as. I think that's a little bit easier. And all of these methods can be obtained using radiographic assistance, such as computed tomography scans or CT scans, ultrasound or US, and liver FNAs typically yield a very low cellularity, but we'll discuss more of that as we go through the actual presentation. For fine needle aspiration biopsies, these are representative samplings of sizable lesions of the liver, and these are obtained by redirection of the needle of multiple passes. On-site rapid assessment of the adequacy and rendering of the provisional diagnosis is done by the cytologist on-site, and this can be used to triage tissue specimens as well for ancillary studies.
So, fine needle core biopsies, they do representative sampling of lesions. So they insert a biopsy needle and they take out, which is basically an elongated piece of tissue. So we do on-site rapid assessment by essentially rubbing the core onto slides and diff quick staining one of them. Um, and we give a provisional diagnosis. So we'll say, hey, it's adequate, you're in the correct area, or hey, we need more tissue. And we also will triage the tissue specimens and say, hey, there's maybe not enough cells here for IHC staining and send out testing. Can you please get more? So hepatocytes are really funky looking cells. So obviously you can see that they are polygonal in appearance. They have really defined borders, and their cytoplasm has these really cool eosinophilic granules in them. They are also sometimes vacuolated, and they have a lot of cytoplasm. The nucleus is centrally located, it's round and oval. The contours are usually smooth, and they have finely dispersed chromatin. They can be seen single, monolayered, 2D, and there can be other cells admixed within the sample.
Some of those other cells include bile duct columnar cells. These are typically not what we're aiming for when we're doing a liver cytology prep, but these can just be kind of needle tracked happenstance, or depending on where the lesion is, you might actually catch some of the actual bile duct, again, either intentionally or not. But these look like your typical columnar cells that you could find in such as the endocervix, the GI tract, not as much mucin as the GI tract, but your standard columnar cells. Normal formations are usually honeycombs, so evenly spaced. Everybody's respecting each other. On the left, if you're a visual watcher, you'll see a pap stain, and then on the right would be the diff quick. These images show very good honeycombs. Depending on the sampling, kind of like the diff quick image, you can get a little bit of misshapen, just kind of depending on the prep technique and the stain. But for the most part, everybody's respectful. You won't see a ton of mucin or vacuoles or things like that. If you do, that would suggest more of like a GI tract contamination. So typically, it's just your nice, flat, even honeycomb sheets is what we're looking for if you see these in a liver sample. Next thing you can see is you might catch some mesothelial cells. These are from the Gleason capsule or the outer covering of the liver, and typically we'll see these in the sheet form of the mesothelial cells, in contrast with something like fluids where you'll get the more rounded, like circular to oval appearance of the mesos. But these are a completely benign finding and are usually just a needle track contamination of some sort, and don't suggest anything one way or the other. It just means you got the outer coating of the liver. For the non-cellular components that you might catch, on the left, if you're watching the actual video of this, are Mallory bodies. Mallory bodies are dense rope-like pink materials that are found inside ballooned hepatocytes. These are made of damaged cytokeratin filaments, and they're a benign finding, but they can be noted in your report if you so choose. On the right, you can also catch bile from the actual bile ducts in the bile duct cells. Bile can be suggestive of malignancy depending on what you're looking for. Bile duct production by malignant cells is considered to be pathogenic in about 50% of cases of hepatocellular carcinoma. However, the presence of bile alone is not indicative to diagnose hepatocellular carcinoma because bile stasis can be common in other benign and malignant conditions of the liver. Okay. For adequacy, very low cellularity is common for liver cytology specimens. Fine needle biopsies, or FNBs, tend to yield higher cellularity compared to fine needle aspirations, or FNAs, but this can vary depending on the lesion as well as the actual location of the lesion. The specimen can be reported as adequate with the presence of hepatocytes and/or evidence of other cellular material, and the specimen is considered inadequate if there is no cellular material present or if cellular components are severely obscured, such as blood or severe inflammation, things like that.
So the adequacy in touch preps or FNA, FNBs is the lesional cells have to be there, which is to explain why the lesion is there. If there's a lot of necrotic debris, if there are granulomatous formations, or just other findings to explain the mass, like if there is like numerous blood vessels, it could be a hemangioma, anything like that. And lesional cells are usually considered malignancy or indicative of like a benign tumor that can be explained and associated with the size and location.
Next, we're going to discuss some liver conditions. I've broken these up into 3 different categories. That would be diffuse, non-diffuse / nodular, and malignant. I won't discuss every single condition that can go on with the liver just because then we would be here for hours on end. So if you're watching the actual podcast, the ones in bold are the ones that I'll be discussing. And then for our audio listeners, the conditions we'll be discussing today are within the diffuse: hepatitis, cirrhosis, and various infectious agents. For the non-diffuse or nodular, I will briefly touch on steatosis or fatty change, hamartomas, hemangiomas, and angiomyolipomas. And then for the malignant conditions, I will mostly be focusing on cholangiocarcinoma, hepatocellular carcinoma or HCC, and then metastatic malignancies. Right, for the benign and infectious lesions. For benign process, I have a couple images of reactive hepatocytes because this is, at least in my experience, more often what you see compared to just regular hepatocytes. Clues for benign hepatocyte nature include smooth nuclear membranes. The NC ratios are still normal. There's rare to no mitotic figures. There's an orderly arrangement of the cells, and there's also what we would call a morphologic spectrum from clearly benign to the reactive or what may be bordering atypical cells. But for the most part, the way I like to see it is if they're uniformly ugly, it's probably more likely a reactive process. So if you're watching the podcast, the image on the right, I think, shows the spectrum very well. You've got your normal small hepatocytes more towards the bottom and maybe towards like 6 and 7 o'clock. They're still relatively on the smaller side, NC ratio, good amount of cytoplasm, and the eosinophilic granules, as Noah described earlier. But then if you look more like 1 and 2 o'clock, you'll get some bigger hepatocytes that are what we would call more reactive, but their NC ratios are still normal. There's not a abundance of cytoplasm, and there's also not a high NC ratio or like super super large nuclei and low amounts of cytoplasm. Eosinophilic granules are still there. They still have their small nucleoli, but contours on the nuclei are still even. Nuclei is still round, chromatin still granular and smooth, and everything is still relatively spaced out the same. Next, to talk about infections, there's a ton that you can get in the liver, but I just wanted to highlight some common ones. Those would be Entamoeba histolytica, Echiniosis granulosus or hyatid worms, and then Strongyloides stercosus. Next, for abscesses, these can be caused by either bacterial, fungal, or parasitic agents, or combinations, other things, etc. These can be described and seen on cytology as abundant excess in acute inflammation. You'll get reactive hepatocytes, or that spectrum of benign to reactive, depending on how severe the abscess is. And when we see abscesses, it's important to exclude an infected metastasis, either from metastatic cancers or even from some like an actual hepatocellular carcinoma that can cause an abscess over time, depending on where it is. Right. Next is hepatitis. This is usually not something that would be evaluated cytologically. This is more of a clinical diagnosis, and we would correlate clinically with a recent diagnosis of Hep A, B, or C. But if it happenstance, we do happen to get an FNA or an FNB of this, typically you would see reactive hepatocytes in a background of scattered lymphocytes. And you can also see what we would call councilman bodies. These are mummified or degenerated hepatocytes with a dense eosinophilic cytoplasm. But again, this is typically not something that would get sent for cytology or cytopathology anyway. This is a clinical diagnosis. Next is steatosis, or fatty liver disease, or fatty change of the liver. And this is caused by an abnormal retention of lipids within the actual hepatocytes themselves. And they can be described by microvesicular or macrovesicular changes. For microvesicular, the lipid displaces the cytoplasm, and then macrovesicular, the lipid would displace the nucleus. So for the visual listeners, on the right side, you have two images. The top is a diffquick, and that would be a microvesicular steatosis because the lipids, which are the white circles, can be seen, and they're not displacing the nucleus. It's mostly displacing the cytoplasm. Risk factors for this include type 1 diabetes, protein malnutrition, obesity, various toxin exposures, anoxia, and hypertension. And they can mimic malignancy on radiology, which is why this might get sampled. The bottom image on the right side for the visual listeners is an oil red O stain. This can be used to help identify the actual lipids, and this can be used on H&E. But some other lipid stains that can also be used in the lab include Sudan black and osmic acid, which are all used to highlight lipid. For other benign lesions, bile duct hamartomas, these are well-formed bile ducts in mature fibrous connective tissue stroma. And on H&E, these can be just seen in Mann-Weinberg complexes, which are embryologic leftovers of bile duct produced in excess. But this typically isn't something you would see on cytology, but just wanted to highlight it just in case.
Hemangiomas are a really common benign liver tumor that are oftentimes cutely named incidentaloma because they're asymptomatic. They are most common in elderly men associated with exposure to chemical toxins. What you would see in an FNA or FNB, which is not necessarily recommended, is smears of ample red blood cells. You can see bland spindle cells, but you'll definitely see if the blood isn't obscuring everything, benign endothelial cells, because this is a poorly vasculated tumor. It's just a bunch of blood vessels coiled together. You would see benign hepatocytes, again, if there is not obscuring blood, and you would definitely see a lack of cytologic atypia. FNA is not recommended, neither is FMB, because if you puncture the vasculature, you could cause extreme bleeding. However, they do say that if you do have to sample it, they would recommend an ultrasounded guided fine needle aspiration.
For the next benign lesion, liver cell adenomas. These are masses that are associated with bleeding and a risk of hemorrhage and can also be painful for the patient. These are often associated with contraceptive steroids. On cytology, if you were to sample this, you would see mostly hepatocytes in 3D cohesive groups. The trouble with these is that the differential diagnosis for these is a well-differentiated hepatocellular carcinoma. So because of that, on cytodiagnosis, it is recommended to say consistent with a liver cell adenoma rather than diagnostic of, just because of the fact that it can be really difficult to distinguish this between a well-differentiated tumor and a benign adenoma. So we never want to say fully diagnostic of and kind of send the patient on their way. If you're suspecting this, it's recommended to perform other studies to fully rule out that it's not the well-differentiated tumor. Next is cirrhosis. This is also called diffuse nodular fibrosis, and this is the replacement of liver tissue by fibrosis, or AKA scar tissue, and regenerative nodules, which lead to progressive loss of liver function over time. This is something that they wouldn't typically send for cytology, but if a patient happens to have a cirrhotic liver and then they need a biopsy for something else, you might see cirrhotic changes. But on cytology, you would mostly see benign and reactive hepatocytes. These hepatocytes should be evenly spaced in flat sheets. The NC ratio should be normal, and then in the background, you would see a mix of fibrous tissue as well as a mixed inflammatory background of both acute and chronic lymphocytes and neutrophils. On the right is a diff-quick image, and then I feel like it highlights everything pretty well. You've got hepatocytes, you can see a little bit of blood, some inflammation, and then chunks of dense fibrous tissue. And then for the histology, which is where this diagnosis I think is a little bit easier and a little bit more helpful, you can see that the normal lobules that you would expect to see on H&E for a benign liver are gone. It's just all been replaced by scar tissue. And then obviously, if there's mostly scar tissue and no hepatocytes, that means that this liver is not functioning very well, aka leading to the loss of function and then all the other problems that come with having a non-functioning liver. Right. Now onto the malignancies. The main liver tumor that arises from the hepatocytes is hepatocellular carcinoma. It is more common in African and Asian descent, but the numbers of incidents are increasing within the USA. 80% of all primary liver cancers are hepatocellular carcinoma, and I'm emphasizing primary for a reason. I'll discuss it later. If a patient has blood work taken, an elevated alpha-fetoprotein is very common. And then for the pathogenesis, a chronic hepatitis B or C infection is associated with this, as well as alcoholism, steroids, various metabolic disorders, and aflatoxin, which is caused by Aspergillus flavus. Then first, hepatocellular carcinoma cytology. These aspirates tend to be very cellular. Malignant cells can be surrounded by endothelial cells, and more distinctly, hepatocellular carcinoma is associated with fine powdery chromatin, as opposed to in benign hepatocytes, where we kind of associate with that darker gross chromatin. If you see fine and powdery chromatin on a cytologic aspirate, that's a bit of a warning sign that you might be looking at something malignant. Intranuclear invaginations are fairly common, as well as seeing atypical scattered naked nuclei, or nuclei that have lost their cytoplasm. Acinar structures can be common, which is highlighted in the second image on the right for the visual watchers. On more of the left side here, that would be considered an acinar structure. Extracellular and intracellular bile can be seen, but as I talked about before, that's only in about 50% of cases, so it's not something to go off of alone. But if you have all these other signs of hepatocellular carcinoma as well as the bile, then that's kind of more leading you in that direction. And what I find most helpful, especially on ROSE or rapid onsight, is the trabecular growth, or the 3 to 10 cell layers thick. Typically for benign hepatocytes and benign samples, it's going to be monolayer or at most 2. But if I start seeing flat sheets that are super thick with again about 3 to 10 cells, but can be more, that's when I'm starting to suspect that there's something malignant going on. Then again, for the visuals, I have some images, but I'll describe them for the audio listeners as well. These are really highlighting those thick plates that I was talking about. Both of the images show a very highly cellular aspirate with, if you were to actually go on the microscope and use your fine and coarse focus adjustments, you would be able to see that this is not 1 to 2 layers of cells thick. These are probably going up to 8 to 10 layers thick of cells. There's also scattered atypical naked nuclei around. The actual architecture of these is a bit irregular, and even on the image on the left, almost looks a little bit papillary to me, or pseudopapillary, because I don't see a core, but the rounded finger-like projections on the edges. For the next malignancy, I'll just briefly discuss cholangiocarcinoma. These resemble well-differentiated mucin-producing adenocarcinomas. These typically present in older patients, so about 60 years old and up. These are associated with parasites, lithiasis, or sclerosing cholangitis. A big thing with these is that there's no bile production. So if you see bile duct cells and bile, that you can favor more of a benign process. But if you start seeing what looks like a typical adenocarcinoma, so the disorganized sheets or balls, even signet rings and no bile, that's when you can start to lean more towards a cholangiocarcinoma or some other type of adenocarcinoma if you're not sure. On cytology, as I already mentioned, you'll see signet rings, which are pretty common, a disordered growth of normal bile duct epithelium, or AKA the disorganized honeycombs, the balls, the rolls. You can also see the loss of polarity, which would be those disorganized honeycomb, and loss of the glandular spaces. For metastatic malignancies, the most common lesion in livers of malignancies is actually metastatic malignancies. These can include from anywhere in the body, such as adenocarcinomas from the colon, the stomach, the pancreas, breast, lung, kidney, etc. Squamous cell carcinomas, lymphomas, melanomas, small cell carcinomas, neuroendocrines, and all of the above. For the visual listeners, I have images of metastatic renal cell and metastatic melanotic melanoma. But again, because the liver is vascular and all of our blood supply goes through the liver at some point somehow, metastatic malignancies are common. And typically, if I'm on a biopsy, I'm more so expecting to see a metastatic malignancy, and I'll always either check the patient history or ask the physician, hey, do they have a history of anything, or are you suspecting some type of metastatic process? Because it is much more common to see this rather than hepatocellular carcinoma. Just some more images of metastatic malignancies. I put an image of a metastatic squamous cell carcinoma as well as a metastatic colorectal. I included the colorectal specifically because of the fact that cholangiocarcinoma is an adeno. So if I see something that looks like an adeno, I most often am going to suspect something that isn't a cholangio, so a metastatic adeno, but wanted to include an image of an adeno just so that way you can kind of see the similarities between a cholangio and then something like a colorectal.
I just want to say, beautiful elongated nuclei on the core picture.
Yes, that is a very good colorectal adeno with those cigar nuclei.
Absolutely.
Right. And then I briefly wanted to touch on some immunocytochemistry and IHC workups that can be done for liver malignancies if that's what we're suspecting. For hepatocellular differentiation specifically, we'll be looking for a HepPAR1 or an arginase 1. For favoring a benign versus neoplastic hepatocytes, glypecian 3, glutamine synthase, or HSP70 can be used. If we're trying to target bile duct epithelium, CK7 and CK19 are very common. If we're targeting Kupffer cells, which are the macrophages that live in the liver, or granulomas, CD68 can be used. For lymphoid infiltrates, CD3 and CD20 are very common. And all other IHC or immunohistochemistry diagnosis are based on specific diagnostic considerations, such as concerns for infections. I wanted to include this really good chart that I actually used to help study for my boards to kind of differentiate on specifically hepatocellular carcinoma versus cholangiocarcinoma and the different traits that can be used. And I wanted to mostly highlight the immunocytochemistry workup. So alpha fetoprotein, like I mentioned before, is very high in hepatocellular carcinoma, but for cholangiocarcinoma, there is no increase in AFP. And then for cell morphology, cytoplasm is more dense and granular for hepatocellular carcinoma, whereas cholangio tends to be more delicate or dense and can even be squamoid at times. And then for special stains, mucin is a with or without for hepatocellular carcinoma, but it's always positive for cholangio. For glycogen, that is positive in hepatocellular carcinoma, but always negative in cholangio. And then for immunocytochemistry, CEA is very importantly negative in hepatocellular carcinoma, but positive in cholangio, and that's because it's an adeno. And then alpha fetoprotein, like I said, is positive in hepatocellular carcinoma, but negative in cholangio. Some challenges and limitations with immunocytochemistry for the liver are limited cellularity. If you don't have a lot of cells, you can't do large IHC panels, and that goes for anything, but particularly common issue for liver cytology. For loss of architecture, cytology can lack a tissue context, which would cause increasing reliance on morphology. For marker overlap, there's no single specific marker that is completely sensitive or specific for hepatocellular carcinoma. So because of that, you have to kind of run these large panels, and then if you get marker overlap and a patient may or may not have history of certain things, it can lead to some confusion. For poor differentiation, this goes for any body system, but tumors may lose their lineage-specific marker expression. So if you have a poorly differentiated lesion and it's in the liver, which is a very common place for metastasis, it can be really hard to diagnose what the specific tumor is if you don't already know the primary site. For background staining, benign hepatocytes can express hepatocellular markers, so it can be hard to differentiate like a typical benign cell versus a very well-differentiated hepatocellular carcinoma tumor. For differential diagnosis, it can be very difficult to distinguish between hepatocellular carcinoma, cholangio, and metastatic carcinoma, particularly if it's a poorly differentiated lesion, and then even more so if it's a cholangiocarcinoma versus a other adenocarcinoma that has happened to metastasize to the liver. And then technical issues for low cellularity in either cell blocks or on the actual slides. There can be fixation artifacts associated, and then also weak staining can affect the interpretation of one lesion over another. But most importantly, for cytology, it is very important to report what you see, especially on rows. And then, again, as I mentioned already a few times, it is very important to know the history of the patient because of the fact that metastatic lesions are much more common than primary hepatocellular carcinoma. So it is always important to get the patient history and kind of have an idea of what you're looking for before making a diagnosis. And then I just included a chart of the 2019 classification for reporting liver cytopathology. This includes benign hepatocellular tumors, malignant hepatocellular tumors and precursors, benign biliary tumors and its precursors, malignant biliary tumors, and that's about it. I included my references, and then I just wanted to thank Noa for joining me today. She did not have to do this on her own time, but I'm very appreciative of both her for doing this today and for being a good mentor to me.
Thank you so much for having me. You did a fabulous job. This PowerPoint was beautiful.
Thanks, and thank you. You did a great job explaining various stuff to us, and I'm looking forward to maybe having you on for other episodes.
I would love it.
Right. And thank you guys so much for listening, and thank you for tuning into the ASCP podcast today. Hope you guys enjoy the rest of your day.
Bye.